Hello and welcome to the next Complete Physio podcast. My name's Chris Myers and I'm here today with Mr. Luke Jones, a very experienced orthopedic surgeon specialising in the knee. Now we're going to talk about ACL injuries today, and we're going to talk specifically about ACL injuries in female sport. And I know this is something that I believe Sky Sports were interviewing about this around the World Cup time. Is that there was around 30 elite female footballers that wanted to go to the World Cup but had ACL ruptures. So this has become, it's had a lot of press recently.
Yep.
And we really want to try and find out a few things around why are female athletes more prone to ACLs and obviously what can be done about it. So let's start at the beginning. What is an ACL rupture?
Yeah, so the ACL is a ligament that sits inside the knee, and it runs in the center of the knee and crosses over with the posterior cruciate ligament. And it runs anteriorly on the shin bone, so from at the front central part of the shin bone backwards inside the knee and attaches into the notch. And it's between 3 and 3.5 centimeters long. It's about 1 centimeter in cross section, and it's made up of collagen, which is a stiff structure that is in fibers. So it's not like a stick, it's made up of hundreds of thousands of collagen fibers. And what it does is it acts like a seatbelt. So as the knee, as you change direction and you put force through the knee, it tightens up, tells you where the knee is in space, and allows you to make pivoting movements.
Lovely. I like the seatbelt analogy. That's a good one. So it's a very small ligament, compared to the rest of our body, but it can be a massive problem, can't it? And particularly in elite sport, it can be a career-ending injury.
Yeah, that's right. And the reason for it is it allows you to make those top-end change of direction movements without thinking about your knee. So it means that you can concentrate on the ball coming over or whatever sport you're doing without worrying about where your knee is in space. And we see thousands and thousands of ACL injuries a year in the UK. It's about 30,000. In the United States, it's anywhere between 100 and 150,000. And interestingly, we see it way more commonly in female athletes across the entire spectrum of performance ability.
So this is what we really want to try and find out today. Why is it that female athletes, and do we know why female athletes appear to be more prone to rupturing their ACL?
Well, I think the answer is that we don't know.
No.
And that's what you and I are both really interested in. And what I'm interested in is, first of all, why might it happen? And second of all, what can we do about modifying it?
And I'm assuming you don't know what to do about it unless you can actually find out why it's happening in the first place.
Well, that's right. So we know what to do when somebody has a torn ACL,
Yeah.
right? And we can talk about the nuances around that. What we don't know is, unless you know why people are rupturing it, how you can prevent them from rupturing it. So surgery is always a last resort with anybody with a medical problem, right? And what we want to do is to stop people needing to have surgery or indeed be treated for the problem in the first place.
Yeah, absolutely. But as you were saying, most athletes who want to return to sort of pivot type sports will end up having surgery if they have an ACL rupture.
Well, there's some very good studies that look, it's difficult with elite athletes because if you are on a very high value contract, then there's no time to try anything apart from an operation.
Yeah,
so
sure.
these patients tend to go straight for surgery. There's a fixed time point they've got to get back for, and it allows the treatment pathway to be quite predictable. But there's some really good studies that have been around for nearly 15 years now, particularly, and you and I both know which one we're talking about, the one that's written by Frobel from the New England Journal of Medicine, 2010. And what that shows is that in non-elite athletes, so you and I, or the vast majority, well, not you, everybody else, but the vast majority of people in the world between the ages of 25 and 45, at least 50% of people can return to the sporting level they want to return to without an operation.
But when it comes to elites, as you say, there's no time to mess around, is there? So they're going to...
Well, that's right.
They're going to end up with a reconstruction.
Yeah, that's right. And we've seen attempts of elite athletes trying to return, if there's a Lions tour coming up or an FA Cup final and people breaking down in that short term. So under those circumstances now, what we tend to do is to say, well, look, you've done it. We need to get you back. Let's go straight for surgery. And I think there's a consensus amongst both surgeons and physios, and there's not always consensus on this topic.
Yeah, no, I think there definitely is.
But I think there is around what we do with elite athletes. But most people watching this, most people that come to anybody's clinic aren't elite athletes, right? Yeah. And so under those circumstances, it's actually harder because there's a nuance in the discussion,
exactly.
right? And we have to think carefully about things. You come to my clinic and you play professional football. I know you're getting an operation, and that's an easy one for me to do. Right? It's done. When do you want to have it done? But actually, what's really tricky is, you're 32. You love playing rugby. You've played rugby for 15 years, and it's how you define yourself. And psychologically, you're devastated about this big injury. You want to get back there with your pals. This is what keeps you going during the week. And now you're hurt. Well, what's the right thing to do? And that's a lot harder than saying, well,
absolutely,
I play football for QPR, pop an ACL in.
Yeah, absolutely. So let's go back to females, because obviously that is our focus here. So we were talking about it before the podcast, and what give us an idea of some of the reasons you think might be responsible for why there seems to be so many ACL ruptures in female sport, particularly obviously a lot of the media is around the World Cup and female football.
Yeah, that's right. And see, the big thing was about Beth Mead and Leah Williamson, right? Around the Lionesses and their injuries that stopped them from participating. And the interesting thing is that depending on which study you read, females per user hour of sport, right, have about a 6 times higher risk of rupturing their ACL. So although more men tear their ACL, that's because more men play sport than females. But if you have men and women playing the same amount of sport, women are 6 times more likely to do it.
That's really high, isn't it?
Well, it is really high, but what's really interesting is that doesn't apply to all injuries, right? So if you look at the big meta-analyses, and you and I were discussing this one a little bit earlier, but if you look at injury rates in team sport athletes between males and females, then men are much more likely to get things like groin injuries, shoulder injuries, upper limb injuries, concussions, etc., etc. But there's something unique about the ACL that makes women much more prone to it. And that's why it's so interesting.
It is interesting.
It's not that women are getting knocked out, women are tearing their bicep, women are tearing their groin, and it's just because women aren't put together properly. So it's not just that. There's something specifically about this injury, right? Yeah,
absolutely. So we were talking, and when you look at risk factors, often people will split them into sort of intrinsic and extrinsic risk factors. So do you want to just talk through what an intrinsic risk factor, and talk about, because you've quite clearly said we don't know the answer, and I think it's important to accept that we don't know the answer at the moment, but there are risk factors, aren't there, that we think may contribute to these things?
Yeah, well, I think the reflective thing to say would be that we know that it's multifactorial. Right, and this is the same with the vast majority of medical problems, let alone surgical problems. Is that there's thousands of factors that all play in together. Right, and when I think about ACL injuries, there's 2 sorts of types. Right, there's a contact injury. You kick me in the side of the leg, and my ACL tears. Well, that's the same for boys or girls. Right, you kick me in the knee, it's going to tear. Women have got. When women rupture their ACL, it's about 65% of the time it's non-contact. And with
so
men,
nobody touches them.
Right, your leg just goes.
They're just generally running, change of direction, pivot, and
deceleration, something like that. Whereas in men, that's only about 50% of the time. And so the question then goes is, well, what is it about the women that means that they have got this much increased risk of not just tearing it, but tearing it when there's no one else involved? And so then we talk about intrinsic and extrinsic factors and modifiable and non-modifiable factors. And really, all this is a way of surgeons and physios and medics trying to simplify it for themselves, right? To put a structure on what we might be able to control or not control. So intrinsic factors are things around the anatomy of your joint, around your genetics, around your family history, around your neuromuscular conditioning, more about your neuromuscular firing of your muscles, about the shape of your skeleton, and then modify, and indeed hypermobility and flexibility and things like that. And then your modifiable, so your extrinsic factors would be things like the training conditions that you operate under, the intensity of the work you do, the frequency of the work you do, the number of participation hours you've had since you started as a 6-year-old.
Could be the terrain that you're, whether you're on a 4G pitch or and what football boots you use as well. All of these things can contribute.
Well, that's exactly right. And I think, there's plenty of good studies that show that there's no difference looking at 4G pitch ACL ruptures between, the rupture rate for women on 4G pitches is higher.
It's higher, isn't it? Yeah. Okay, so you've got your intrinsic and extrinsic. The other thing to mention, I think, with the intrinsics, it's certainly got a bit of press, is around hormonal changes and obviously the menstrual cycle and the changes and how that could influence the ligament.
Yeah, that's right.
Is there anything on there that we can, actually hang our hat on in terms of, are they more likely to get injured at a certain phase in their menstrual cycle, or do we know any more about that? Because it is being extensively studied, I believe, looking into that.
Yeah, that's right. And this, so we know that the female hormone profile changes ligament laxity, and we see this the whole time, particularly around giving birth, right? I mean, that's the whole point, is that your hormone profile changes allow you to pass a baby through the birth canal. So quite clearly, change in hormone profile affects ligament laxity. And there have been a lot of suggestions that this might be related to different parts of the menstrual cycle. But if you look at the studies and you look at the big meta-analyses and systematic reviews of this, it's really not clear.
It's inconclusive, isn't it?
I think so. And so while we're enthusiastically looking at that, from what I've read, and of course this research isn't going to be being done by surgeons, right? It's not clear. And then the question goes, well, how would you modify that in the first place? And now what are we saying? We're going to be controlling menstrual cycles in females.
Or do you reduce training intensity at certain, it's not that. And that's the other thing we were talking about earlier, is that it's all very well finding out what's wrong, which is the first thing we've got to do. But then what do you do about it? And some of them you can't modify, which is what you're going to go on about, and then the others you can modify.
Yeah, so I think if you were to talk about modifiable and non-modifiable risk factors, at least what that lets you do is to say, well, this guy's a high-risk person. So if you had a load of athletes who were under the age of 20, who were hypermobile, who were valgus, who were doing pivoting sports, who had a family history of ACL rupture, right? So these are all non-modifiable. Well, you might say, well, in this case, we need to look really closely at those athletes and treat them slightly differently during the warm-up, during their training, during their training load, and not work them as hard under fatigue as maybe some of the other athletes.
Yeah, and I think there is something in that, and I don't work in professional sport now, but you can imagine that those are, when they're looking at injury screening, I'm sure these things are being picked up. I still don't think we know what to do with that information.
That's right.
And is the coach going to be happy if you say, well, they need to sit this one out because of X, Y, and Z? Before they know it, they're not getting contracts. There's pressure to play.
Right. That's right. And I think that's one of the problems we have as clinicians, isn't it? That people come into our clinics and want answer to these questions. And very, very often it's tempting during a 30-minute consultation to try and give someone an answer. But I think what you really need to do is to be reflective enough and respect the intelligence of your patients enough to say, look, we don't know. This isn't clear. I can tell you these facts, and then we just have to put it together and work together to try and get the best result for you.
Right? And the other thing that I was reading about, just from, because there was a lot of attention around the Women's World Cup, was about a lack of research in this area. Now, do we actually have just because we don't have the answer doesn't mean there's a lack of research. It means we don't have the answer. So is it just that people aren't spending money or focusing too much on male sport, not female sport? Is that the case? Or is actually we're doing enough, or we're doing a lot of research in this area, but we still just don't know the answer?
Yeah, well, I think it might be, again, it's probably quite complicated and a little bit unclear, but if you look on PubMed, which is the database that we all use when we're looking up research papers, right? And anybody can go online and look up PubMed and type in what they're interested in. And one of the interesting things that PubMed does that not everybody notices, but if you look in the top left-hand corner, you'll put a search term, ACL, and it will show you in the top left-hand corner the number of papers that were published per year since PubMed started, which is, 50 years ago, something like that. And first thing you'll notice there is that, if you did your PhD in the 90s, you only had to write 3 papers and they'd all be published, right? But actually, interestingly, in the last full year that we've got on PubMed, which is 2022, because we're sat here in November 2023, so there were approximately 3,300 papers published, with the key term being ACL, right? And then if you do a separate search, which is ACL female, then that's around 650 of those 3,000. But it's very rare to read a paper and they're not subdividing it by male or female. So papers just on female ACLs, there's over 650 or around 650 published a year.
Which is a fair amount.
It is.
I suppose some of that won't be high quality.
So I think the point about the fact that there's that many papers published a year is that the vast majority of it's not high quality. And that's why you and I rely so much now on meta-analysis and systematic review. And the problem with meta-analysis and systematic review is that when you read them, the conclusion is always the data that's been put in here is not very high quality, so we need more research. And then you and I sit here and go, well, we're not clear, right? And the answer is not clear.
And what do you do with that patient in front of you as a result of the research?
There you go. And I think that's a really interesting topic, and one that I've struggled with as I've come sort of through my training, is that as clinicians, we're asked to take a population-based data and apply it to the individual sat in front of you. And I think that's a really difficult thing to do. And particularly when you're in a binary profession like surgery, where it comes down to you're either having an operation or not. So you're taking complicated, sophisticated questions where you've got thousands of patients on a population basis, and you're bringing it down to a black and white answer, right?
And all you can then do is inform the patient, give them all the information they can, and essentially they have to make their own.
Well, that's exactly right.
That's all you can do.
I think that's what it has to be. That combined decision-making model is so important. Right?
So because obviously some of the factors we've talked about, or the risk factors, we can't control. So let's talk a little bit about the things we can control.
Okay.
So those are things around, because we also know that the more elite they are, I think the higher the risk is as well. So, and that's the same across the board with men as well, is that if you are, for example, the Premiership have greater injuries across the board than the Championship.
Okay.
You know, is it just that it's a higher level? I don't know. It's not necessarily specific to ACL, but just across the board. So things like if somebody's watching this at home and say they've got a daughter. You've got a daughter, haven't you?
No.
Not ready.
I don't think so.
Okay, let's say you had a daughter.
Mixing me up.
And they're getting to the age where they're 17. You're like, actually, they've been taken on by an academy. They're and they've actually they're pretty decent. But obviously, you read the press, and every other injury is an ACL reconstruction, which we know can be career-ending, and we know they're going to be out for a year. What can we do, or what we know about, to prevent that at this stage?
Well, there's a number.
It's a big question.
That is a big question, and I think we can sort of look at that in two ways. First of all, we say, is it to do with the sort of training and the conditioning that they're doing? I think that's a topic you and I are both interested in, and we think probably it is. And then there's a second bit which says, well, what can we do to prevent it? And that brings us on to the FIFA 11 Plus and the Australian recent stuff, and the Power Up to Play that the Skip charity are putting together around warm-ups, and how we know that really reduces injury rates. I think the thing that I've been interested in relates around ACL tear rates in elite dance athletes. So if you look at dancers where males and females start dancing at the same age, and they have the same conditions, and they have the same footwear, and they dance, let's say, approximately the same intensity, and they have a large number of acceleration, deceleration movements, a lot of twisting movements, which you and I both know can have 13 times body weight going through you as you pivot or decelerate. Right, so males and females start at the same age, they do the same training intensity under the same conditions, and they work out under fatigue, 90 minutes twice a day if you're a performance dance athlete in London around the corner here. The ACL tear rates are the same between men and women, right? And when you look at the way that they land and their neuromuscular activity, it's the same between men and women. And so that suggests
that is really interesting.
It's really interesting. And of course, there's a bit which goes, well, look, if you're an 18-stone man or a 13-stone woman, then there's something about that strength in a collision. Okay, that's fine. So let's take collision ACL rates out.
Non-contact ACL.
Because it's hard when it's collisions involved. But non-contact ACLs, where we would expect for the females to have a higher rupture rate, and we just do not see that in elite dance athletes. And that probably relates to the quality of the training, the intensity of the training, the number of participation hours that the female dance athletes and the male dance athletes
and the fact that they have, I think it's changing actually, isn't it? Where, if you look at football, obviously loads more women are playing football, they're starting earlier, there's loads more teams. So maybe what we'll find is when everything levels up a little bit, maybe those ACL ruptures do reduce and become more like the dance where they're developing, or they've got the same sort of number of training hours. They're doing the same sort of training load. Then I think you know.
Well, that's interesting, isn't it?
Yeah.
Because it's not uncommon for female ACL injured patients to come to my clinic who are rugby players.
Yeah, yeah.
And for them to be university students.
Yeah, yeah.
And I'll be like, well, how long have you been playing rugby for? I took it up at freshers.
Yeah,
right.
Exactly. There was nobody at the stall,
so that's pretty common, you know. And you're like, well, if you're, you know, whereas if you were to turn up to any men's university rugby team, these guys have all been playing since age 8, right? And so there must be something about that if you are taking up a sport like that at that age, then your conditioning work is not going to be enough. You just haven't got 10, 15 years of training in your knees, right?
Yeah. And that definitely links us into prevention, because what we're talking about there to a certain extent is your ability to perform skilled movements, to be agile, to have good neuromuscular function, which is obviously it's a bit of a vague term actually, but it's, you know, if you watch somebody that, you know, is good at football, they look pretty smooth. Yeah,
it's the way they move.
Yeah, it's the way they move. Whereas if somebody's just started football, it looks a bit of a mess, doesn't it?
Yeah,
they
right.
look like they've got poor balance. They, you know, and all of that. And I think when you look at the prevention programs and the ones you've talked about there, the FIFA 11 plus, the Perform Plus in Australia,
that's right.
Then there's lots of other trials that have clearly shown that if you implement the right sort of movement patterns in a warm-up, that you can prevent an ACL injury.
Yeah, and the numbers are quite dramatic. Right?
They are.
I mean, I'm sort of going through here because I don't want to give people the wrong numbers.
Yeah.
But they are really, really high. You know, 30, 40, 50% reductions.
I think one was 53%. It's like, that's crazy.
Yeah, it's quite remarkable, right? And the interesting thing when you read those papers is not that it works or not, because I mean, it's surprising how much it works.
Yeah.
We're not surprised it does work.
Yeah.
That they're struggling to get the coaches to engage in it, right?
So
because it takes 20 minutes out of the warm-up, and indeed the Australian one talks about you have to do it at the end for the warm-down and things along those lines.
The good thing about the programs is they're all slightly different. And so it's almost like you don't have to follow it completely.
Right.
But you could, you know, you can have a play on that theme.
Yeah.
So I think you've alluded to something really important there. The first thing is, why do these occur? Well, we don't know at the moment, but hang on, we do have some prevention programs, particularly in adolescents and female adolescents, that show that you reduce ACL injuries. Then we come on to the hardest problem of everything, which is execution, implementation, and actually people following it and doing it.
Yeah.
And I think that's where, like you mentioned, the SKIP charity, which is basically saying, you know, anybody involved in sport, you know, if you're a coach for a local team or whatever, have a look at this, because I think the SKIP charity has a really good online resource. It's got all the information you need. Just implement it.
Yeah.
It's not hard.
Right. No, that's right.
And I think that's something, even if we can't research it and say, you know, this is why it's happening, because it's not as simple as that. But actually, we've got a tool to prevent it. But we need to implement it.
So I think to some extent, Chris, it's not that we don't know why it's happening. It's just that it's so multifactorial that we can't. That if you came to me and said, "Oh, well, you know, it's hips and hormones," right, the old classic, then it's just not just that, right? And so it comes back to that bit where we're looking for a simple answer to tell people in clinic. But it's not a simple answer. No. It's a sophisticated, multifactorial problem that needs a regression analysis to work out the significance and importance of each of those factors. Right?
Absolutely.
And so it is. I don't think it's we don't know. It's that there isn't a single thing that we're going to modify on individuals. And indeed, some of the things that put you at increased risk, you can't modify. Part of the reason people play sports is because there's a danger element involved, right?
The adrenaline.
So, that's right. So that's why people want to do it. You're beating somebody, you're under fatigue, you're the winner, et cetera, et cetera. So we're never going to get to a stage where there's no injuries, right? But I think that what we need to be looking at is what we can do to prevent as many unnecessary injuries as possible.
Absolutely. Right? And when you look at the programs, they generally look at three sort of themes. So strength is one.
Right.
So it would appear that just being stronger is good, but it needs to be specific to the sport. And obviously, you know, how many, you know, at what age did a female athlete first start lifting weights? You know, all of these sorts of things need to be considered. You know, I'm not talking about people smashing it out in the gym, but going through some strength training. The other thing they looked at is how agile they are. So looking at agility. So we know we need to be strong. We know we need to be agile. And then the other thing a lot of the programs have put in is plyometric training. So essentially bounding, you know, jumping. And I think those are the three components that from what we know should be involved. Less so things like balance, interestingly.
That's interesting.
Which you thought might be more appropriate, but it's that ability to change direction with good control, and it's the repetition of movement. You can't. That's the problem with non-contact. You don't know exactly what angle the knee will be at, what position the foot will be in, to be able to practice that and, if you like, harden it. But you can put yourself in situations where it is replicating that to a certain extent.
So how does that work though? Because intrinsically, what you'd imagine is that patients or players would be more likely to rupture under fatigue. So when their muscles are tired,
most injuries occur at the end of the first half or second half.
Right. So that's why we see people wearing heart rate monitors. So we know that where they're sitting in their fatigue levels, so that we want to avoid a soft tissue injury. So people are being brought off the pitch based on what we're seeing on those monitors. Right.
In training.
Sure.
Never in
that's a different
that's
thing.
The problem,
right? That's what pitchside medics can decide on that one. But so how then does it work that you're doing a warm up? How does that help with preventing injury? Because the warm up, you're not under fatigue, right? So I can look great. I can look great in the first 5 minutes, Chris. But it's in the 78th minute that it's tough, right?
So I definitely don't have the answer. But what I would say is, when you carry out the warm up, but it's like anything. If you implement research, you've increased awareness. So there's always going to be an element just by implementing something like that. People are a little bit more aware. Maybe they're a little bit more careful when they pivot. I don't know. So there's always that element. But when you're looking at neuromuscular, you're obviously warming up the movement patterns. If you like, people talk about activation, firing up.
That's what they mean, right?
I think that's what they mean, isn't it? And therefore, you're preparing your body for what that sport needs to help with. And therefore, there must be, assuming that, you know, if you can reduce things by 50%, there must be some carryover from the warm up into the match.
Well, it makes sense, doesn't it? Because I suppose the reason we practice, you know, if you're a rugby athlete, the reason you practice your passing the whole time is so that when you're under fatigue, your skills are reproducible. So that's just a neuromuscular pathway, right? So I suppose there's no reason why that would make a difference with your
Maybe you should do in your training setting though. That they haven't done this, but maybe you should finish your training and then do your neuromuscular, because you're then under fatigue.
That's probably the time when you should be doing it as well.
Or just get fitter so you don't get so tired. Which wouldn't be so easy.
But it's interesting, isn't it? Because if you are a middle-aged man who likes playing five-a-side on a Thursday, and you're rushing out of the office to get to the 4G pitch, and you've got the wrong shoes with you, and you're dehydrated, you're not going to spend the first 15, 20 minutes warming up, are you? You're just going to go straight into it. And you see those patients in your clinic
all the time, but don't think that that's just individual to, you know, people that are late. I think the warm-up, obviously when you get to academy level sport, you would expect that this is happening. But I don't believe across the board in the general population at schools, at colleges, at local clubs, I don't think this is happening. And that's why Skip Charity, trying to get this information out there, because actually, wow, we've got pretty good information to say we can reduce this. But there needs to be that exposure to it.
And it needs to be fun, doesn't it? I mean, I took my little boy to mini rugby up the road here in Regent's Park yesterday, and if the first thing I do when I arrive there at 9 in.m. is tell him to
take him through the fifth
that's right. He just wants to do drop goals and pretend to be Johnny Wilkinson, doesn't he? So I think we've just got to work it out that the kids are certainly, it has to come in right from the beginning, doesn't it? From when you start and be brought all the way through.
Does he know who Johnny Wilkinson is?
Well, I keep telling him. I know who Johnny Wilkinson is.
You don't say George Ford.
He's got a Marcus Smith Harlequin's top. So exactly right.
Okay, so look, I think we've covered most areas there. So just to conclude, Luke, and feel free to add anything here. We don't know exactly why, but there's definitely things that we can implement that may reduce the prevalence of these injuries. We've got a good operation for it. I mean, the research on that is quite clear that it's a good operation. Just actually one last thing, re-rupture rates in women. So if you've torn your ACL and you have a reconstruction, are you more likely to re-rupture as a woman?
Well, I think it's a really interesting topic, and there are certainly some studies that show that you are. There are other studies who show that actually males are more likely to re-rupture.
Right, okay.
Because they're more likely to get back to sport.
Okay, interesting.
Okay, so then it becomes a little bit more sophisticated than that, right? So is a study we got here from the guys over in, this is just another systematic review and meta-analysis, right? And as I said before, I'm sure there'll be people watching of like, well, I've read this study, I've read that study, 3,600 studies in the last year.
You can't read them all.
I can't read them all, but what I do like to read is what do the guys say that have reviewed all the studies on it, right? And what this will tell you is that male and female patients with ACL injuries, similar outcomes regarding their rates of revision, but male patients were found to have statistically higher outcome scores.
Right.
So the men do better.
So therefore they get back to a higher level.
And then they rupture their ACL. They rupture
their other ACL.
Well, yes. So that's interesting. So they've got higher rupture rates of their good side and the side that you reconstructed. And I think that you and I both know that when you and I do a reasonable amount of revision ACL surgery on patients that have had their ACLs reconstructed elsewhere and have failed, often because their rehabilitation, they haven't engaged in their rehabilitation properly, right? And you and I talk about the details around an ACL reconstruction. The number one thing is about how much you do your rehab, right?
Absolutely.
And but what we do see is that the males, although they do better than females, they go back and their re-rupture rate is
because the risk is higher because they're working at a higher level of sport, I assume.
That may well be right. I think the other problem as well is, isn't it? They've got to come back to see you. And there's this whole thing about, I've come to you with my sore knee and I hit you around the face with a fish and you never came back to see me. So I'm saying it went brilliantly. Well, that's because you hit me around the face with a fish. And so if if I come,
that's a new one.
It might be that they just stop engaging with the medical professionals because they've had enough, right? Like, this is my knee's gone. You thought you were going to make me better. Now it hasn't got better. And we just lose touch with them. But I suspect it's more
and that made me think of another question is, do you see more bilateral ACLs in women where they've done both knees, within their career? So is there anything on that?
So I couldn't, from my own personal experience, say that, and I don't know about the data about that, but it makes sense, right?
It does,
that if you've got high risk factors, then you're 6 times higher, then you're much more likely to have bilateral ACL rupture. What is interesting is your family history.
Right.
So if you have a family history of ACL rupture, then you're 2.5 times more likely to have an ACL injury
for men and women.
And that's across the board. Wow, so that is not separate between men and women, and that's probably partly genetic, although there's not going to be a single gene loci for that. It's probably more a familial aggregation, right? So your mum is hypermobile, you're hypermobile, your mum loves soccer, you love soccer.
Of course.
Therefore,
and probably quite good at it as well.
Well, there you go, right? And she gets you out there because she played at university and now you play, etc., which I think is an
it just goes to show how risk factors are so hard to control to really actually get the answer that we sort of set off to answer.
Right.
So we've probably given people more questions than answers, but that's fine. Thanks very much for your time, Luke. I really enjoyed that. And fun. Well done for all your pre-reading.
Yeah, well, I know you obviously email me on Sundays about the topics you want to talk about, so I don't want to make sure I got it too much. But I think the interesting thing is, I think that point though that we're making there, Chris, is that if anybody thinks they've got the answer, they probably haven't. And the really reflective thing is to say, look, we're not 100% sure. This is what the data shows us, and that we're moving towards what the right answer is. There are no black and whites in the human body because it's extremely sophisticated machine
and individualized, and everybody's situation is slightly different.
And so you'll hear surgeons talking about these sort of personalized ACL reconstructions, which is what we all like to talk about. But I think what's really important in getting people a super result from this is the teamwork between the clinicians, you, I, the sports medics, the radiologists, and the patients, right? And
the coaches and the parents.
So it's just a big Venn diagram to getting everybody back to where they need to be, right?
And I think my last thing to say is, if you are a coach or if your kids at school, try and make people aware of the Skip charity. Because I think there's lots of useful resources in there. And if you want to do one thing to try and prevent an ACL, it would be, as we know it would be to start one of these programs such as the FIFA 11 Plus to try and prevent their ACL. So thanks very much for your time.
Appreciate it, Chris. Thanks very much.